Morning. I'm Catherine Shaw with the Kentucky Regional Extension Center, and I'm here to introduce our first speaker. Mary Luvisi is going to speak to you about improving outcomes for patients with diabetes. Mary is a quality improvement advisor with the Kentucky Regional Extension Center. She joined us 4 years ago and has 31 years of experience with the Cabinet for Health and Family Services, Kentucky Health Information Exchange, and with us at the Kentucky Regional Extension Center. He currently serves as the director of the Kentucky Diabetes Learning Collaborative. Mary has a passion for patient engagement, quality improvement, and healthcare transformation. During the session, if you have questions, please put them in the chat box, and if we have time, Mary will answer them at the end of the session. If we run out of time, we'll contact you after our event and answer them individually. Take it away, Mary.
Thank you so much, Catherine. Good morning, everyone. I couldn't think of a better way to start the day than talking about how to improve outcomes for our most vulnerable population, our patients with diabetes. So my session is going to provide you some tips and successful quality improvement strategies to help improve those outcomes. The first step, first of all the examples that I'm going to give today, I'm pulling from the Kentucky Diabetes Learning Collaborative, which started in October of 2019 and is wrapping up actually this month. And this, like Brent mentioned, is a project that is funded by the Center for Disease Control and is run out of the Kentucky Department of Public Health, our very valuable partners. So the first step for any quality improvement strategy is to choose the strategy you want to utilize. There are many strategies out there, and we'll talk about the one that we chose. And we want to make sure that the strategy is patient-centered and evidence-based. And then you want to identify your resources, because we all can't be experts in everything. So we've got to pull together the best experts in that field to help you along your way. The strategy we chose for the Kentucky Diabetes Learning Collaborative was the Breakthrough Series Learning Model from the Institute for Healthcare Improvement. And that model is designed for breakthrough improvement in a short period of time. Our collaborative was originally designed for 12 months, and then it was extended to 15 months after requests from our practices and as a result of the pandemic. So we're just wrapping up this month. The first step is to select your topic, and of course it's diabetes for us. Then to recruit faculty. We recruited from across the state experts, endocrinologists, experts in the field of health IT, patient safety, had a great team of advisors, and we developed our framework for the quality improvement strategy, and our framework was around the chronic care model, which is evidence-based and patient-centered. Then we enrolled our participants. We recruited practices from around the state. We gave them some pre-work because we wanted to know what their baseline was, where they were with their diabetes improvement work. And then the framework involves 3 learning sessions. Learning session 2, we build a foundation. Then we have an action period where we do emails, visits, phone conferences, monthly team meetings, getting those reports and doing assessments, and begin starting our Plan, Do, Study Act, which I'll mention in a minute. And then we go to learning session 2, where we fine tune it. We get some more experts in to help us along the way. And then we go to a learning session 3, more fine tuning, finding out from the practices what's worked for them, what hasn't worked. The things that have worked, we go ahead and have them spread to other providers, other locations. And then at the very end, we do a Congress, which we were going to be doing on December 15th for this group, just to highlight everything that they've learned across the course of the learning collaborative and to highlight their success. So these collaboratives provide the participants an opportunity to be a part of a network of experts and to share ideas with their fellow learners. The key elements of breakthrough improvement is, first, you have to have the will to make the change to a new system. Again, it's a very condensed period of time, so you really have to have the will Our practices showed extreme effort in the face of the pandemic. They still made great strides and great improvements. You have to have an idea on what on which to base the design of your new system. Again, the chronic care model was a great framework, and the Institute for Healthcare Improvement strategies provided us with the design, and then the execution of those ideas across the practices to make them work. So 3 fundamental questions for improvement. What are we trying to accomplish? How will we know that a change is an improvement? And what kind of changes can we make that will result in an improvement? So with the model for improvement, and you may have, I've heard about this before. There are several different methodologies or different names that people use. But the question, what we are trying to accomplish, is the aim. And that's set out what your goal is for the project. Then how will we know that a change is an improvement? We've got to select our measures. What are we going to measure to make sure that we're making improvement? And qualitative and quantitative measures. And that what change can we make that will result in improvement? An idea. What can we try? Some of your frontline staff are a great source of the best ideas because they're dealing every day with the patients. So they may have a great idea for how you can change something just a little bit to make an improvement. And then you run it through the plan, do, study, act cycle. That's a small test of change. It can be just one patient or one provider for 1 week. Try new things, see if it works. If it doesn't, then tweak the idea a little bit and start over. You might have heard of this. It's been called the Schwartz cycle, the Deming cycle, the plan, do, study, act cycle. We call it a plan, do, study, or PDSA. So with the repeated use of PDSA cycles, again, you have to start with an idea and run it through those changes. If you've ever gone to Cracker Barrel and done that little peg game, the first time you do it, you may end up with 4 pegs left in there. And then you kind of learn, if I shift this way, it might work better, and you end up with 2, or you hit it on the nail the first time and you end up with just 1 left. So you just have to tweak those small changes. An example of that was, how can we increase foot exams for our patients with diabetes? One of the practices suggested, well, if it's a patient with diabetes and they're coming in for an appointment, regardless of what the purpose of the appointment is, when you room them, have them take their socks and shoes off. That way, when the provider comes in, it'll trigger the provider to remember, this patient is due for a foot exam for diabetes. And so they'll go ahead and follow through with that foot exam. It was just a small change. Have them take their shoes and socks off. And it results in improvement of increasing the number of foot exams that you're completing. Next slide. All righty. So this is a great group of participants, practices that are currently involved in the Kentucky Diabetes Learning Collaborative. We have One Cross, Pennyroyal Community Medical Clinic, TJ Regional Health, Health First Community Health Center, and Kentucky Care. They've been amazing to work with. Some of them have had EHR issues. We've had the pandemic. We've had staffing changes. But throughout the whole process, they have contributed. They have fought for their patients, and they've made great progress. So really proud of all the effort that they put in, and they have just been an amazing group to work with. A little bit more about them on the next slide. All righty. So they are all, it just so happened that they all kind of ended up being from Western Kentucky. So as you can see, they cover a large group of counties in Western Kentucky. And it was interesting for us because most of our chronic disease management work previously had been focused on Eastern Kentucky. So it was a great opportunity for us to expand out to the western part of the state and see where we can help them with their quality improvement efforts. Their regional numbers, we had a total of 28 locations, 86 providers. The patients with diabetes, 7,883. The patients with an A1C greater than 9, which is considered out of control, was 3,325, or 42.2% of their patients had diabetes that was out of control. So you can see the need was very great in this area. And we also had some great partners to work with them in our local health departments that are a valuable resource. If you're not using them currently, I would encourage you to reach out to your local health departments because they can be a great partner in helping your patients with diabetes. Next slide. All righty. So the goal of our project was 5 to 10% improvement in the core measures of diabetes care. Those core measures were get that A1C lower than 9. We also included blood pressure control. We wanted to get their blood pressure less than 140/90. We wanted to increase the referrals to diabetes self-management education and support. So those were primary measures, and they were required for the project. The secondary measures, which were optional, but many of our practices chose 2 to 4 of them, were increased retinal eye exams and foot exams for patients with diabetes, increased influenza vaccinations, increased attendance in diabetes self-management education. Be sure to document those self-management goals. And then we also threw in those qualitative measures of patient satisfaction and employee satisfaction, because when you're doing all this work, you want to make sure that it's something that both your staff and your patients found valuable. So we included those as well. Again, I talked about the chronic care model. It's designed to help practices improve patient health outcomes by changing routine delivery of care in 6 interrelated areas that are patient-centered, and evidence-based. And the areas that are talked about were community, the organization of healthcare, self-management support, delivery system design, decision support, and clinical information systems. So we wanted to have an informed, activated patient and a prepared, proactive practice team to improve the overall outcomes. And I'll give you some examples from the chronic care model from the Kentucky Diabetes Learning Collaborative of the things that we incorporated that fit into those 6 categories. I'm not going to highlight them all because you'll get the slides, but again, the community, the local health department's partnership, that was invaluable in our project. Self-management support, the nurses and the registered dietitian initiated processes for becoming licensed diabetes educators, provided new educational material. They made referrals to diabetes self-management and medication nutrition therapy, and telehealth services for diabetes self-management. Obviously, they became very important with the outbreak of the coronavirus. Then organization of healthcare. The CEO was visibly supportive of the project. Each practice had a physician champion, and they attended the in-person learning sessions along with the practice managers or quality managers to understand completely the project and all the resources that were available. Clinical information systems, they fine-tuned their population health modules. They created reports to track those patients and those measures. They made sure to flag and incorporate those referrals for DSMES so that they could track those, because that was something they weren't originally tracking. And then under decision support, they made sure the structured data fields were added, that their ITI was creating reports that could summarize the care that that was being provided. Some of our locations actually have retinal eye scanners for that initial assessment of the patient, and so they trained more staff on how to use the scanner, so that as a patient came in that was in need of an eye exam, they would do that initial screening with the retina camera, and if there was any issues, then they would refer them further on to the specialist. Delivery system design. Again, I talked about before the provider entered the room, having them take off their shoes and socks. They had walk-in anytime for blood pressure checks. They utilized the retina camera. They had the pharmacist referral was incorporated to optimize their medication management. Another thing they did as a result of COVID-19, they started doing drive-through labs so that they could take the patient, check the patient's blood pressure and check their A1C to make sure they were on track. Throughout the whole process, data validation is critical, and Brent is going to talk about that in the next session, so I won't go into too much detail, but we are focusing on a sample size of 10% of reviewing the patient's charts and determining if they should be included in the numerator, if they should be included in the denominator, and just keep in mind throughout the process that it is an ongoing process. It's not a one-time event. We found in more times than I can even care to mention that if there was some type of system upgrade, something would get disconnected, and so they wouldn't be pulling the right numbers on their report. So you're doing the work. We want you to get credit for it. You're taking care of your patients. So we have to make sure that that data is pulling and it's valid. Some of the topics I talked about, bringing in experts to help you. Monthly we had meetings with practices, and we would do an educational session as well as just an update from each one of the clinics on how they were doing. So we brought in an endocrinologist. We brought in an expert. The National Diabetes Educator of the Year talked about the language of diabetes, how patients shouldn't be defined by their disease, but they are a patient with diabetes. They're not a diabetic patient. We brought in eye experts, foot experts, experts in self-management support, chronic care management experts. We talked about, in June, we had a special segment on chronic care during using telehealth. We talked about motivational interviewing, diabetes distress, which is a real issue for our patients. We talked about diabetes and kidney function. Last month, our practices attended the Kentucky Diabetes Symposium. And then on December 15th, we're wrapping up with our Learning Congress. A little bit over on time, so I'll hurry up. Just want to give you a snapshot of how the collaborative as a whole is doing. Everything is green, means that we're at or above our target for improvement. Blood pressure control, a little bit below our target, but hopefully with this month's reports, we'll be at target for that. So despite the pandemic, they were all able to still reach their goals. So we're really, really proud of their success. Next slide. If you're not aware, the Kentucky Department of Public Health is offering diabetes self-management support utilizing telehealth, and it's a very valuable tool for your patients with diabetes. So there's information available on this flyer about those telehealth courses. And next slide. There's also the Kentucky Department of Public Health has a diabetes resource directory. You can find on this, you can do a search on this directory and find classes in your area, not only for diabetes self-management support, but also diabetes prevention, so we can catch it early before they become type 2 diabetic. The benefits of building or participating in a quality improvement coalition are increased awareness of and support for participation in educational services. It helps improve outcomes for your patients with diabetes. It aligns with and augments other quality improvement efforts to improve health care, reduce costs, and move to value-based care. It helps enhance your population health efforts and expand continuity of care. There's assistance and support for improving care and care processes. It's a rich environment for sharing ideas and knowledge while learning and applying the methodology, and it builds it's a broader team-based approach. So the next steps, you can build or enhance your own coalition. You might already have one in your area, or you can participate in an established one, and I'll talk a little bit about that in the next slide. We want to encourage you to use a model for improvement back in your office for your improvement efforts, and remember to implement those small tests of change, and if they're successful, spread. If they're not, that's okay. Tweak it, start over, and try it again. So if you are interested in participating, we are having another round of the Kentucky Diabetes Learning Collaborative in 2021. We're currently in the recruitment phase. And then in February and March, we'll have informational calls for interested groups. The applications will be due March 17th, St. Patrick's Day. We'll have a kickoff call in April, do data validation in April and May, have our learning session 1 in May, learning session 2 in October, 3 in February, and then wrap up with the Learning Congress June 15th of 2022. And we invite you to listen in on our December 15th Learning Congress from 12 to 2:30. That's where all of the practitioners involved will actually give their final reports and talk about everything that they did from the very beginning to the very end, what worked, what didn't work. So we'd love to have you. The Zoom information is there, so help yourself. Join us at that time, and we'd love to have you. And for contact us, again, that's Mary Levisi. That's my email. And Michelle Hibbard on our team is part of the Diabetes Learning Collaborative as well. So you can reach out to Michelle. And any questions? I think we're a little over on time.
Yeah, if you do have any questions, thank you so much, Mary. That was a great presentation. If you have any questions, either about the things that Mary presented on or about joining the next Learning Collaborative, you can send them directly to us, and we will get them to Mary and